Good evening, everyone, and thank you for joining us tonight for the Primary Care First Office Hour that's being co-hosted by the American Academy of Family Physicians, the American College of Physicians, and the American Medical Association. We're really pleased to have you here tonight and hope that this will be very useful and educational for everyone. Next slide, please. So this is just a disclaimer just to be sure we're all set before we head into the discussion today. All the information and material being presented here is for educational purposes only and is accurate at the time of this presentation and really is intended to represent not the only or necessarily the best methods, procedures, etc., appropriate for the application process for the Primary Care First Cohort 2. And it's also intended to really present an approach, view, statement, or opinion of the faculty, which may be helpful to you, but may not be applicable to every practice or situation in which you find yourself. So we do recommend that every practice review their own situation, data, etc., when determining whether or not to apply or participate in the model. Next slide, please. So I'm just going to run through what we're going to be doing tonight. First, we'll kick off welcome and introductions, which is what I'm doing right now. I'll introduce myself momentarily, and we'll then provide an overview. CMS will provide an overview of the Primary Care First model. The American Academy of Family Physicians will review some Primary Care First use case scenarios. Then we will have Dr. Larry Ward, who is a participant in Cohort 1 of Primary Care First, to provide a physician perspective that we think might be helpful to you as you consider applying. And then we'll have a live question and answer session that will be moderated by AMA and will allow you the opportunity to hear answers to your questions from the CMS staff. Next slide, please. So we have three panelists joining us today from CMS, from the Innovation Center. First, Nicholas Minter is the Director of the Division of Advanced Primary Care at the CMS Innovation Center, which is responsible for the Comprehensive Primary Care Plus and Primary Care First models. He's worked at the Innovation Center at CMS for over 5 years, originally developing and leading the Part D Enhanced Medication Therapy Management model. Before coming to CMS, he worked at the Department of Health and Human Services in the Office of the Secretary, where he advised on hospital payment policy and ACA implementation. Second, we'll hear from Sandra Erie. Sandra Erie is the PCF and Comprehensive Primary Care Plus model co-lead and payment lead with the Division of Advanced Primary Care at CMMI. Prior to joining CMS in 2020, she was a Senior Health Policy Analyst at Kennel & Associates, where she specialized in healthcare coverage and reimbursement policy for the Department of Defense TRICARE program. And our third panelist from CMS is Emily Johnson. Emily joined the Division of the Advanced Primary Care at CMMI in 2019. She currently works as the model co-lead for the Primary Care First and CPC Plus models. Prior to joining CMMI, Emily worked at the Advisory Board Company, where she helped health systems conduct strategic planning for their telehealth programs. And previously, she'd worked for MedPAC, advising Congress on Medicare policy. Next slide, please. Your moderators today are myself, Sherry Erickson, I'm Vice President for Governmental Affairs and Medical Practice at the American College of Physicians. We'll also be hearing from Kate Friedman, who is Care Delivery and Payment Strategist with the American Academy of Family Physicians. And finally, the question and answers will be moderated by Jennifer McLaughlin, who's the Assistant Director of Federal Affairs at the AMA. Next slide, please. So just to let you know, you can submit your questions throughout the presentation using the Q&A feature at the bottom of the webinar. We will keep an eye on that and hopefully get to as many of those questions as possible. We also received many questions from you in advance and have reviewed every single one of those and appreciate all of those being submitted. So we will kick off tonight's Q&A with a subset of those questions that were asked by a number of people. So we'll try to at least get those taken care of and then answer other questions that you may have or that may come to you during this live presentation. Finally, we will also plan to put together a set of frequently asked questions, particularly for those that we aren't able to get to during this presentation, and we'll post that with the webinar recording on each of the society's websites after this event. So that way we'll try to get to as many questions as possible here, and then some that we can't get to after the webinar so that you can find those answers as well. So at this point, I'm going to turn it over to our CMS panelists to take it from here and provide a primary care first model overview for you. Thank you.
Great. Thank you so much, Sherry, and thank you everyone for joining us today. We really appreciate that you're spending your time with us here at the end of the day, and we're looking forward to the discussion. So my name is Emily Johnson. I am the PCF model co-lead, as Sherry mentioned, and my colleague Sarah and I will be giving a brief overview of the primary care first model here. Before diving in, I just want to make sure that everyone is aware of the revised application deadlines that we announced yesterday. So the deadline for PCF practice applications has been extended to May 21st, 2021, and the deadline for payer applications has been extended to June 18th, 2021. And with that, I'm going to dive into the overview here. So Primary Care First, or PCF, builds on the principles and lessons of other primary care value-based payment models that we have run at the Innovation Center at CMS. In particular, it builds on our experiences with the CPC Plus model. So the CPC Plus model was focused on practices that were either just beginning or in the midst of developing advanced primary care capabilities. And it was designed to help practices develop these capabilities by making upfront investments and also applying small and upside-only performance-based incentive payments, as well as offering a robust regional learning and coaching system and implementing more prescriptive care delivery requirements. Now, in contrast to that, Primary Care First is aimed at practices that have already developed advanced primary care capabilities. And this difference in focus means that PCF is designed to reward practices for delivering better outcomes, but it's less prescriptive about how practices achieve those outcomes. So there are fewer care delivery requirements here and also less reporting. And there is also less hands-on learning support than in CPC Plus. So in sum, Primary Care First is designed for practices that are delivering advanced primary care to their patients already and are looking for a payment model that rewards them for these efforts. Next slide, please. Now, all models in CMMI define success as either improving quality without increasing costs, reducing costs without reducing quality, or in the ideal scenario, accomplishing both quality improvements and cost reductions at the same time. PCF seeks to lower costs by reducing acute hospital utilization, or AHU in particular. And the theory here is that primary care practices can have a meaningful impact in preventing avoidable hospital visits, which then in turn will have a large impact on cost and quality. PCF also aims to improve quality and access to care for attributed beneficiaries by tying the model's potential performance bonus to meeting certain quality standards, which we'll go into more detail on what those specific quality standards are in a bit. But compared to CPC Plus, in Primary Care First, practice performance on these quality and utilization measures is going to have a much larger impact on payments that practices receive under the model. And these larger payment incentives are a key part of the PCF model test. One last thing to note here is that PCF, like CPC Plus, is a multi-payer model. So CMS is working with payers to align with the PCF model in areas of payment, quality, and data provision. And the goal here is for practices to be able to focus on providing care for their patients in a consistent way across the board, regardless of their payer status, which hopefully reduces practice burden and also provides a consistent set of resources and supports and also objectives to be working towards. Next slide, please. This slide shows the 26 regions across the United States where Primary Care First is being offered. So this includes the 18 states and regions where CPC Plus is currently being tested, which are that kind of blue teal color on the map. And then it's also being tested in 8 additional regions, which are shown in orange on the map. The first cohort of the model started in January of this year, and we currently have about 850 practices participating, as well as 14 unique payers, although several of those payers are participating across multiple regions. And cohort 2, which we're recruiting for right now, will begin on January 1st, 2022. And both CPC Plus and non-CPC Plus practices across all of these regions are eligible to apply. Next slide, please. I'll talk a little bit more now about eligibility. So to participate, all primary care practitioners in any given practice must be in good standing with CMS. And primary care practitioners are defined as an MD, DO, CNS, NP, or PA who is certified in either internal medicine, general medicine, geriatric medicine, family medicine, and/or hospice and palliative medicine. And at least 50% of the total Medicare revenue billed by the practice's participating practitioners must come from primary care services. And that's just kind of a check to make sure that we are bringing primary care practices into the model. Additional information about how we define those primary care services is available in the request for applications, which we'll reference a couple times throughout and is located on the CMS website and also linked here in the chat today. Practices must have a minimum of 125 attributed Medicare beneficiaries. And they must also be able to demonstrate prior experience with value-based care and value-based payment arrangements. And this can include both arrangements with Medicare and arrangements with other payers. Then practices must use the 2015 edition of Certified Electronic Health Record Technology and support data exchange with other providers and health systems. Additionally, they must have the advanced primary care delivery capabilities that are discussed in more detail in the RFA. And these include things like providing 24/7 access to a practitioner or nurse call line and impaneling patients to a practitioner or care team. All things that if you have participated in CPC Plus will be very familiar to your practice. So I'm now going to turn it over to my colleague, Sarah, to talk through the PCF payment structure.
Great, thank you, Emily. So PCF introduces a two-part payment structure. This includes a hybrid total primary care payment, or TPCP, which incentivizes advanced primary care at the same time compensating practices with higher risk beneficiaries. The other major payment component is a performance-based adjustment, or PBA, which is on the right. This rewards practices for meeting key performance standards. And the TPCP is adjusted quarterly based on practice performance on one of two outcome measures, AHU, as Emily mentioned, as well as total per capita cost. Through the PBA, practices will have the opportunity to increase their total primary care payment by up to 50%. Next slide, please. All right, so I'm going to briefly talk about the payment elements separately, starting with the total primary care payment. This is made up of two payment types, a population-based payment known as the PBP and a flat visit fee. So the PBP, which is on the left-hand side of this slide, is intended to compensate for care both in and out of the office, as well as support the longitudinal care relationships at the heart of primary care. PCF, as a model, increases reimbursement for practices caring for patients with complex chronic needs relative to historical fee-for-service revenue. And we achieve this by adjusting the PBPs by practice risk group. So each group is associated with a per beneficiary per month amount ranging from $28 to $175. And those four risk groups shown here will be determined based on the average CMS HCC, which is a hierarchical condition category, risk score of a practice's attributed patient population. Practices serving a relatively average risk population, which are group 1 practices, will receive the $28 per beneficiary per month, whereas practices with a higher risk population in groups 3 and 4, particularly group 4, will receive $175 per beni per month. And that compensates them for the more resource-intensive care that their patients require. Practices will receive the same monthly PBP for each attributed beneficiary, regardless of individual patient risk scores. Also note that the PBP will be reduced through a leakage adjustment, and we've received a ton of questions about the leakage adjustment, so I will go into a little detail right now. The leakage adjustment is intended to hold practices accountable when beneficiaries seek primary care services outside of the PCF practice. And this adjustment is calculated quarterly based on a lagged rolling 1-year period of service dates and will first be applied for cohort 2 practices during Q3 of 2023. So the third quarter of the second performance year. Just for some context, for example, the first leakage adjustment will include beneficiaries who are attributed during the first calendar year of their performance, so 2022, and qualifying services from that same period. For each practice, we calculate the leakage rate quarterly by dividing the number of attributed beneficiaries qualifying services billed by any clinician not on your practice roster by the total number of qualifying services from any practice. In order to promote the delivery of face-to-face services as appropriate, primary care services provided to your attributed beneficiaries will receive the same fixed per visit payment. So that's the flat primary care visit fee on the right side of the slide. And in 2021, the national flat visit fee base rate is set at $40.82. A common question received about the flat visit fee payment and codes is whether these codes can be billed regardless of whether the service is provided in person or via telehealth. So if a practice meets the current Medicare requirements to provide one of these services via telehealth, and there is a complete list of flat visit fee eligible services, I think in the appendix, it's also in the payment methodology paper. But if they meet requirements to provide one of those via telehealth, then the practice will receive the flat visit fee for the service. One requirement example would be originating site requirements as modified by current Medicare waivers in response to the COVID-19 public health emergency. Any Medicare telehealth or virtual care services that are not included on the list of eligible services I just mentioned will be reimbursed according to Medicare fee-for-service policies. And just as a reminder, the PVP is paid prospectively at the start of each quarter, while the flat visit fee is reimbursed through the standard Medicare claims processing system. Next slide. All right, so I'm just going to spend a few minutes walking through the steps to determine each practice's quarterly performance-based adjustment, or PBA. This will begin in the second performance year. This slide shows the 4 factors that determine a practice's PBA amount, and those 4 are the quality gateway, the national benchmark, regional performance adjustment, and continuous improvement or CI bonus. Next slide. So the first step in the process of determining the PBA amount is whether a practice meets the minimum quality standard on a set of measures that we collectively call the quality gateway. And the quality gateway was implemented to ensure that practices meet these minimum quality thresholds before they're rewarded for reducing utilization or cost. The quality gateway contains different measures for practices in risk groups 1 and 2 versus those in risk groups 3 and 4, in recognition of, again, the different clinical needs of the relatively healthy versus relatively sicker beneficiary populations. So as you can see on the slide, for risk groups 1 and 2, the measures included in the gateway are the patient experience of care survey, 3 ECQMs, including a diabetes, hemoglobin A1C poor control measure, a controlling high blood pressure measure, and a colorectal cancer screening measure, as well as advanced care plans, which is a merit-based incentive payment system, or MIPS, clinical quality measure. For practices that fall in risk groups 3 and 4, the gateway consists of 2 of the same measures that I just mentioned, the patient experience of care survey and advanced care plan, as well as a 3rd measure, days at home, which is still under development, but will be included in the 2022 quality gateway. All right, I will now turn it back to Emily to talk briefly about data sharing and the timeline for the application.
Thanks, Sarah. So one of the key elements of Primary Care First is data sharing. And CMS will be offering participating practices data to inform their efforts to impact quality and utilization. So participating practices will receive regular Medicare fee-for-service expenditure and utilization data, and will offer both patient identifiable and practice level quarterly data feedback reports. These reports will include expenditures, top diagnosis codes, hospital utilization, and specialty care utilization. And we'll also provide national and regional level data so that practices can benchmark their performance against other practices and have a sense of how you're trending on the performance-based adjustment measures. Practices will have 2 options for how they receive data under the model. So they'll be able to request claim and claim line feed data or receive an interactive data feedback report. And the claims data option is meant for practices that have more advanced data analytic capabilities and are able to work with that claims data, whereas the data feedback reports are more curated and allow practices that don't have some of those more advanced data analytic capabilities the ability to view data in an organized, interactive, and user-friendly dashboard. And I should say those 2 options aren't mutually exclusive. A practice could opt to receive both of those options. Next slide, please. So I'm just going to end here with our timeline. As I mentioned, the application deadline for practices is Friday, May 21st. And then applicants will be notified about their acceptance in late summer or early fall of this year. And we'll be onboarding accepted practices to the model in time for a January 1 start date. One thing to note is that the applications are non-binding. So if you submit an application, you are not obligated to then participate. You will receive a formal participation agreement and have the option to sign and move forward or not. The full request for applications is linked here on this slide, and we've referenced it a couple times, but if you're looking for more detail on any of the policies that we've gone through today, that's a great place for that. And then we've also provided the link for the official application portal here. I think with that, I'm going to turn it over to Kate Freeman at AAFP to go over their PCF payment calculator.
Excellent. Thank you, Emily. If you can go to the next slide for me. So the AAFP has created calculators for practices to assess the financial impact of participating in Primary Care First. At a high level, the calculator allows you to compare the revenue you might expect to receive in PCF at a certain performance-based adjustment to what you will receive for the same set of services in fee-for-service or CPC plus. There are a few assumptions we've built into this calculator. The first is that the calculations use the calendar year 2021 Medicare physician fee schedule, national non-facility payment rates to estimate the expected fee-for-service revenue. These values aren't adjusted anyway, including for geographic practice cost index, the GPCI. So again, this fee-for-service revenue is an estimate of what your practice may receive. So that's part of the disclaimer here, is that obviously that's not adjusted for the GPCI. The second is that we did build in a flat leakage amount, and as Emily and Sarah noted, the leakage doesn't apply to PCF practices until the third quarter of the second year of the program, but we wanted to make sure that practices were aware that there was a leakage adjustment within the program. So we set that at about 15%. And that's applied to the population-based payment. So again, your practice's leakage rate may be higher, lower, or relatively the same as what we've set in there, but we did set a flat leakage rate just so that you all could have an idea of what it might look like. And then the last assumption that is included in the calculator is that it does not include any coinsurance. Since the coinsurance in the model is based on the Medicare physician fee schedule allowed amount for the submitted claim under traditional fee-for-service, as opposed to the flat visit fee amount, it's essentially the same in both models, so we didn't include that for that reason. The other reason we excluded it is because there is the option to waive coinsurance in PCF, and we were trying to limit the variability of the calculator. So that is excluded from the calculator. So we created a couple of use case scenarios. The first one we're going to walk through is 2 use cases for non-CPC plus practices, and then we have one that's specific for CPC plus. And to note, there are 2 versions of the calculator, one for practices that are not in CPC plus and a version for those that are participating in CPC plus. So in general, this model is looking at a practice that has 5 FTEs with 2,000 attributed Medicare patients that fall into that group 1 with an average HCC of 1.12. The first scenario is a practice that has 1 FTE of a care manager that does 250 care management CCM a month and an annual wellness visit rate of 25%. And the second scenario is looking at a practice that has 2 FTEs and how the change in CCM and annual wellness visits might impact the revenue and fee for service, and looking at that in comparison to Primary Care First. So if we can go to the next slide. So this is that first scenario with that 1 care manager in a non-CPC plus practice. And you'll see the population-based payment is the dark gray bar, the light gray bar is the flat visit fee, and the blue line across the graph is the fee-for-service revenue. So that's what we kind of look at as like the tipping point. So as you can see, the fee-for-service is approximately equivalent to primary care first revenue with a 0% performance-based adjustment. So essentially those two are approximately equal. So if you're participating and this is what your practice kind of looks like, you might expect that without a performance-based adjustment, your revenue would be approximately similar to what you would make, what you would be reimbursed for under fee-for-service. So for the next scenario, we'll go to the next scenario. This is for a practice that has an FTE of about 2, and you can see how this just moves where that tipping point is up to about a 10% performance-based adjustment. So again, it's really just about what your practice looks like. And the calculator is, you would put in all of your individual data to see what this really looks like for your individual practice. If we go to the next slide, we can look at a CPC Plus practice. So this is modeled after a Track 1 practice. So this Track 1 has received $339,000 in care management fees and retained 70% of their performance-based incentive payment. So that's about $42,000. And we're looking at essentially the same practice as we did before, with 2 care managers and a 50% annual wellness visit rate. So if we go to the next slide, you can see that this slide, this orange line is CPC Plus, and all of the other color, the blue line is still fee for service, and then the revenue for PCF is still the bar graph. So for this, you're really looking, it's close to 20% is really where that tipping point is for CPC Plus. So when you're thinking about the transition from CPC Plus, it's a little more complicated, and you want to take into account, there are some things you have to think about in terms of that, because you aren't in CPC Plus, you weren't allowed to bill CCM. So you have to kind of estimate those things and make sure it's going to be kind of a rough estimate of what you think you might bill under fee for service. So in general, these tools are available to anyone. They're not behind the firewall. There are links at the end. I'll also mention that obviously these were developed by the AAFP. The CMS had no part in developing these. So just to throw that out there, if you have any questions about them, you can reach out to us directly, and we're happy to have conversations about the calculator or any questions you might have that come from its use. Next slide. So with that, I think it's time for us to hear from a physician who is participating in the model. So if I think we're going to unmute Dr. Lawrence Ward.
Hello, can you hear me okay?
Yes, we can. Thank you very much for joining us.
Thank you, I appreciate the opportunity. So my name is Larry Ward. I'm a general internist in Philadelphia at Jefferson, and I'm governor for the ACP in Pennsylvania. I run our primary care practices and the quality and practice transformation efforts at my system, and have had a central role in the implementation of CPC Plus and PCF, as well as our system's MSSE program and ACO. So I was asked to talk a little bit about our experience so far with PCF. And as background, my system really went all in with CPC Plus with over 60 practice sites. So obviously we're not a small single practice, we're a larger system, so that will color some of my thoughts here, but I thought it important for you to know that. The proactive payment system for CPC Plus worked very well for us, and we were successful in building out multiple new programs, including care coordination, a follow-up process after all ED and hospital visits, integrated behavioral health, and others. We've been very pleased with the program, and believe it has really had a tremendous benefit to our patients, as well as our clinician satisfaction. For our non-CPC Plus sites, we prioritize enrolling them in a new CMS program. So when PCF opened, we enthusiastically enrolled them. We understood it's a different program and with a different emphasis, but I want to share a few points about our experience so far. Obviously, it's quite early, but I'm also happy to add more if you'd like. This is going to just be brief. The revenue neutral aspect of the program, while understandable, does not really have the upfront revenue and akin to the care management funds that we had in CPC Plus to allow us to really comfortably hire additional resources. So we already have pretty wary practices after COVID, and with the prospect of downside risk, it's really meant that we have been much slower to hire any additional or create and build out programs than we were with CPC Plus. On the other hand, we have really appreciated that Primary Care First is allowing more flexibility, especially with how practices can meet program requirements, such as allowing practices to choose the mechanism for patient engagement, for instance. We like that we've basically taken the CPC Plus things that we did and how we met requirements through that and sort of applied it to PCF, even though it hasn't really designated that's exactly how we have to do it, but we appreciate the flexibility with that. I have two other brief points. One, similar to CPC Plus, our region at least, is essentially a single payer program. The commercial payers are not really meaningfully participating, again, as they did not with CPC Plus. So that makes it difficult for us. And we really do like the idea of the multi-payer program. Secondly, while CPC Plus had a robust support network, we've been told that there is no plan for program support that is going to be provided with PCF, and we found that disappointing because we did enjoy those and we appreciated the assistance they gave and the regional meetings as well. So we're exploring enrolling our current 60 plus CPC Plus sites in Primary Care First because we want them in a CMS program. But currently our participation comes with some hesitation because we're not sure of the financial and patient care benefit for us and for our patients, and are currently most concerned about having to trim some areas that we've built for CPC Plus because of the change in the financial question that it brings. And I like the calculators that you showed, but as you showed for CPC Plus, for many of our practices, we need to get a 20% upside. And so that has us a bit concerned about moving forward into PCF. Our plan is still to do that, but we are concerned about it going forward, and just wanted to share that with all of you. And I appreciate the opportunity to do so.
Great. Thank you, Dr. Ward. This is Jennifer McLaughlin with the AMA. And now we're going to move into the interactive section of the webinar. So first up is a quick poll question to gauge how likely you are to apply to participate in the Primary Care First model. There it is. You all should see it on your screen in front of you. And we will not be displaying the results of this poll during today's webinar, but this information is really valuable to CMS and to our societies as we plan and gauge your interest in the model and think through future resources as well. So thank you everyone for taking the time to engage and respond to that webinar poll. We really appreciate it. While that poll is still up, just as a reminder, we continue to ask that you submit your questions using that Q&A box at the bottom of your screen. CMS will be answering live Q&A in just a few minutes. Okay, great. Looks like everyone had an opportunity to respond to the poll, and we really appreciate it. So we're going to kick off the Q&A session with a few of the questions that were submitted by you all as you registered for the webinar. There were some really great questions that we thought were probably fairly applicable across the board, and wanted to start with these questions. So the first one has to do with eligibility and the PCF application. What should a physician practice consider in terms of dual participation in an ACO and PCF? And how will dual participation impact our ACO benchmark?
Yeah, sure. Thank you. So I'm Nicholas Mentor. I work here at the CMS Innovation Center and would be happy to take that first question. So just for context, if you are a primary care practice that is currently in an ACO that is enrolled in the Medicare Shared Savings Program, you are eligible to apply for primary care first. If you are in the next generation ACO model, then you're not able to apply. But want to make that distinction up front. I know most of the ACOs are in MSSP, and we do allow overlap between the two programs. In terms of how dual participation between MSSP and primary care first will affect your benchmark, in essence, at the beginning of the program, it will not affect your benchmark at all. Your benchmark will be based on historical spending, which would be set based on years prior to the model. Where dual participation will impact the ACO outcomes, if you will, is in the shared savings calculation. If a primary care practice that is part of an ACO is in MSSP, then we will factor in all model revenue as part of that shared savings calculation to determine, when CMS determines whether or not the ACO owes shared losses, gets to share in savings, or is in the middle where they're not sort of reaching the minimum loss or gain on either side. So that's how it will impact. It will not affect the benchmark up front at the beginning of the model at all. And just to elaborate for a second, in terms of what are the benefits of being in both models, I just want to highlight that primary care first changes the method of payment. If you're in MSSP, then typically you are still receiving fee-for-service reimbursement, but primary care first would allow most of that funding to go to a capitated format. And also for those ACOs looking for a structured way to reward primary care practices for the value they're injecting in the system, then primary care first offers an avenue to do that. So hopefully that answers this question, but happy to talk more if more questions come in. And with that, I will pass it to Emily.
Thanks, Nicholas. I think we're on to the next slide, which is, how is this program different from CPC Plus?
Yeah, so I'll take this one. And I think Dr. Ward did a really good job of covering this already, so I'll try to keep it brief. But I think there's kind of a fundamental philosophical difference in what kind of practice CPC Plus versus PCF is designed for. So CPC Plus was really designed for practices that were kind of at the beginning of their journey of practice transformation and value-based care. And because of that, provided a lot of support for participating practices. So it's got upfront funding that's been referenced, the pretty robust regional learning network and coaching, a pretty small also performance-based incentive payment. So your ability to impact your payments under the model through your performance is limited to a pretty small overall share of your revenue in CPC Plus compared to PCF. So that's another big difference. And then CPC Plus also was pretty prescriptive in what kinds of care delivery requirements it expected practices to be implementing in exchange for those upfront payments. So it was providing a lot of structure and guidance for how to set up those capabilities and upfront funding. But then the flip side of that there wasn't a ton of opportunity to impact your overall revenue by delivering great outcomes for patients. Whereas PCF, in contrast, is really designed for practices that have gone through that practice transformation experience, whether it's in CPC Plus or another payer's value-based model or another sort of CMS value-based program and has been able to build those capabilities and is ready for sort of taking off the training wheels and doing more sort of self-directed work. So not as much guidance on what sort of care delivery interventions look like. But the flip side of that I think is nice that Dr. Ward references, it's more flexibility. There's less reporting requirements. So CPC Plus has financial reporting where practices have to report how they're using the extra model payments. That does not exist in PCS. It's something that we know practices find quite burdensome. So that's something that we have done away with in PCS. And then there's also an opportunity to really be rewarded and receive a significant boost to revenue through delivering strong outcomes. And we think we see in our practices that, for example, our participating in CPC Plus, based on their performance there and the advances that they've made, that we expect many of them would be able to do quite well under the performance-based adjustment methodology that we have in PCS.
Great, thanks, Emily. Next slide, please. There were a number of questions that came in during registration about payment, and in particular, one question about the increase in Medicare payment rates for office visits. Medicare did increase those in 2021. Will those increases be reflected in the PCF flat visit rates?
Yeah, so this is Nick again. I wanted to highlight a couple things in responding to this question. One, I think we appreciate the concern raised that Medicare rates change every year. And so there's a very valid question about what does that mean for the total primary care payment, which is supposed to be equivalent to what we receive in fee for service. Are we freezing it in the first year? Does it change, et cetera? And I guess to reassert, I should say, something that we mentioned briefly in the presentation. Our goal in running this model is to make sure that we provide through the flat visit fee as well as the population-based payment a revenue that is roughly equivalent to what you would receive in fee for service. So as that changes year over year due to changes in the physician fee schedule or otherwise, we will be updating or assessing whether or not we need to update the population-based payment and the flat visit fee rates. In terms of, the question here is a little bit more specific, will these increases be reflected in the PCF flat visit rates? I think the method and the manner in which we would provide any update or rebasing is something that we will continue to look at. Just to note, the flat visit fee is the rate that you get when you bill an office visit. It's unclear to us whether or not it makes more sense to increase that rate versus the population-based payment. Frankly speaking, personally, I think as we move to more capitated payments, we may want to look there first. But just to note, our goal is to make sure that we stay current with increases in the physician fee schedule, and we'll be rebasing or increasing the payments throughout the model to make sure that happens. Thank you.
Thank you, Nicholas. Next slide. There were a number of pre-submitted questions about leakage, and in particular, this question, which asks if a primary care physician sees patients at 2 locations, but is assigned to only one PCF practice, how will an attributed patient seeing their primary care physician at the non-PCF practice location impact the PCF practice's leakage rate?
Good question. This is Sarah. I will answer that with a bit of a long-winded answer probably. So if the 2 practices, so the non-PCF practice and the PCF practice, are at different physical locations but share a TIN, and the attributed beneficiary sees one of the PCF practices, PCPs, at the non-PCF practice site, this would not count as leakage. We are calculating leakage using the combination of TIN NPIs for each PCF practice. So in this case, the attributed beneficiary's visit is still considered within the PCF practice. Now, if the PCF practice and non-PCF practice are within the same system, but do not share a TIN, then any qualifying primary care service that the attributed beneficiary seeks at that non-PCF, but same system practice would count as leakage. And that's the case even if the beneficiary is seeing one of the PCF practices, or in this case, maybe their primary care physician at that non-PCF practice site. So in this case, that physician will have two distinct TIN MPIs, one for the PCF practice, one for the non-PCF practice, and the beneficiary's visit with their practitioner at the non-PCF practice site will count as outside of practice. And the same would apply to other practitioners within that system practice. Keep in mind, I want to just reiterate that qualifying primary care services that count towards leakage are not subject to the PCF model's flat visit fee adjustment, which we've gone through a little. Instead, Medicare reimbursement for those outside of practice visits will be at full fee-for-service rates. So if it's within your health system, you shouldn't be losing revenue for those services and for that leakage, but the leakage adjustment is used just to make sure that the prospective population-based payment that the PCF practice receives is relatively accurate in accounting for their patient panel.
Okay, great. Thanks, Sarah. Next slide, please. What data will I receive before signing a participation agreement?
Yeah, this is a good question and an important one. So I think we want to be clear that practices will be able to have more information to kind of help them assess the feasibility of the model before they actually have to commit to participating by signing a participation agreement. So we'll be using information that you submit in your application to calculate a couple of estimates for you. One will be providing an estimate of what practice risk group you will fall in, and that ties to what population-based payment level you'll be receiving. So we'll provide that estimate as part of your acceptance packet. We'll also be providing an estimate of the number of attributed Medicare beneficiaries that we would expect you to have under the model. And then we'll be providing a list of our payer partners. So you'll be able to see what other payers will be participating in your region, are currently participating and have been offered participation in this second cohort. And then in addition to that, we'll be sharing an updated payment methodology paper. So there's a payment methodology paper for PCS currently available on the website, and we'll just be providing an updated version of that with updated policies for 2022 for participants as part of your welcome packet. And again, you'll have time to consider that information and what it means for how the model impacts you before you have to actually finalize your participation.
Thanks, Emily. This is the last question that was pre-submitted that we'll go over, and then we'll move into the live Q&A, and it is about risk adjustment. And how will patient acuity status adjust over the course of the 5-year agreement period?
Yep, this is Sarah. I'll try to take this one. So first, I'll just briefly answer how CMS calculates the practice risk group. So the PCF risk groups are set annually at the start of each performance year. And your practice's risk group is assessed at the practice site level or TIN MPI combinations. And it's based on the average CMS HCC risk score of your PCF attributed beneficiaries, and that is the beneficiaries that were attributed in the previous year. I'll just add to that. I've seen questions as well about how often the risk grouping is recalculated and will it change during the year? A lot of you have asked about this. The answer is it's recalculated annually. The risk group and corresponding base rate population-based payment amount will remain constant throughout each performance year and will be recalculated before the start of each year of your participation in the model.
Thanks, Sarah. And next slide, and I will turn it over to CMS now to address the questions that have come in during this webinar.
Yeah, sure. So this is Nicholas Minter, and I'll take a couple to get us started. I appreciate there's a number of questions that have been submitted and want to encourage our attendees to continue to submit more so that we can answer as many as possible in the time we have left. So one question that we've gotten a couple of times is the relationship between primary care first and the comprehensive primary care plus model. I know, Dr. Ward talked about this earlier, and I think that there's a question about CPC plus and what comes, sort of next is primary care first. How does it relate, and what should practices be looking forward to in the future? And I want to note that as Comprehensive Primary Care Plus, sunsets, we are continuing to look at how to engage with practices that are earlier on in the primary care transformation continuum, if you will. Primary care first is a model that is for practices that we believe are advanced in their care delivery and are able to assume limited downside risk for what is a much more increased upside and more flexibility in how that they provide care. And so, we are testing primary care first in all of the same regions that we have tested CPC plus, because we believe that models that have gone through CPC plus are ready for primary care first, and taking on that limited downside risk in exchange for, for significant representation of value on the other side. We will continue to think as part of our portfolio at CMMI, the Innovation Center, for how to continue to engage practices that may not be ready for primary care first, but wanted to sort of to note the way that we look at the primary care world going forward, and are really excited about the potential of primary care first. One other question I wanted to tackle, which is a broader question, is whether or not primary care first represents a net investment in primary care. To take a step back, I will note at the Innovation Center, and I know me and my team personally, we believe that primary care is an essential foundation for healthcare worldwide, not just in the United States. And we believe that overall it is not sort of represented in payment congruent with the value that it provides. And so primary care first is intended to be a net investment in primary care. It has a limited downside of negative 10% for those practices that are significantly, sort of performing below par in order to provide a reinforcement, or if you will, an incentive for them to improve. The upside is much higher than that. So from our standpoint, we believe that practices that enroll in the model, being compared to other practices that are in their peer regions, we expect to see practices incentivized, moved by the payment model to provide higher quality results, to reduce utilization, and to earn more money as a result, frankly speaking. And so from that standpoint, we do believe it is the opportunity for a net investment in primary care significantly above what fee-for-service represents currently. And with that, I'll yield to Emily to answer a few more questions.
Thanks, Nick. All right, so we had a couple of questions about the flat visit fee and how it works and what services it applies to. So we have designated a specific set of what we consider to be essential primary care services, mostly office visits, E&M visits, AWV is included in there, transition of care visits, kind of that make up the core primary care office-based visit set is included in our flat visit fee code set. And so all of the services in this set will receive the flat visit fee of about $40. Now that is balanced in addition with the population-based payment, which is meant to provide a proportion of the regular revenue for those services through a partially capitated payment. If you're interested in the full set of codes that are included in that flat visit fee code set, that is available in the request for applications that we've mentioned a couple of times. I just want to be clear that it does not apply to all services. So more procedurally based services, for example, are not included in the code set, and any services that you don't see listed there would just be reimbursed at regular fee schedule rates. Okay, then there was a question about what is the distribution of practices in cohort 1 across the 4 risk groups. And what we're seeing is that the predominant share of practices is in the first risk group. So it's about 85–90% of our practices that are falling in risk group 1. And then the remainder of practices are fairly evenly divided, although trailing off a little bit in the remaining 4 risk groups. So unless you know that you serve a pretty complex chronic population, it's a reasonable assumption to expect that you are likely to be in the risk group 1. But again, this is something that you'll receive an estimate of as part of your acceptance packet. And so you'll be able to kind of have a feel for where you're likely to end up in the model before you actually need to commit. All right, I think I'm going to pass it to Sarah to answer a couple more questions.
Thanks, Emily. So I want to follow up on one question about risk adjustment. A few people have asked what claims period is used to determine the practice average risk score. So assuming that you all are cohort 2 practices starting in January of next year, the period in which will be used for the first year risk scores is 2020, final 2020 risk scores, which are calculated using diagnoses in Medicare claims from 2019. And those will become available this spring, and that's what will be used for your first performance year. CMS uses the most recently available risk score to assign practices to risk groups, and to ensure that a relatively complete set of diagnoses are captured in this score, we calculate risk scores at least 12 months after the base year that contains the diagnosis claims information. So final risk scores aren't available for a given year until the spring of the following year. And we do have more information about the PCF risk adjustment methodology in the current payment methods paper, which is available on CMS's website. We also have a PCF CMS HCC risk score fact sheet, which I'm happy to link in the chat. I just wanted to remind people that this was developed for cohort 1, and that when it references program years, it will be slightly different for cohort 2, but otherwise the information should be valid for both cohorts. And then I also want to address questions about CCM, so Medicare Chronic Care Management Services. We have a set of CCM services that are related, so we call them CCM related services, and that full list of CPT codes is also in the payment methods paper, and I think the RFA. But PCF practices are not allowed to bill for that set of services using the respective CPT codes for any of your attributed PCF beneficiaries. We consider them duplicative of the population-based payment, which already incorporates reimbursement of those services in the base rates. I don't see any more questions, but I will pass it off, I think, to Nick. If Nick, do you have any others to answer live?
Yeah, sure, I'd be happy to. There are a couple of questions on 2 different topics that I can take briefly. The first is, how competitive is the selection process? The application process, while we've tried to streamline it on our end, still does require time away from patient care. And so, I think there's a reasonable question about whether or not practices can be assured of success, or how assured they can be of success before they apply. I will note that Primary Care First is not a competitive application process. We will be accepting members based on their ability to meet the eligibility requirements, which Emily covered a little bit earlier in the PowerPoint presentation, and is also covered in more detail within the request for applications, which was linked in the chat earlier and has been referenced several times, and is on our CMS Innovation Center website for Primary Care First. So if you meet those requirements and you complete the application successfully, then you should be allowed in the model. So I want to make sure that we are explicit about that. And the last question that came up is one that we hear from time to time about snowbirds and leakage and alignment. And the question is, if a patient lives in New York and goes to Florida for the winter, will there be an exclusion if they see a PCP in Florida? Just to be very, very careful here, if a patient is aligned to your practice in New York and they go to Florida and see a primary care physician, as long as they stay aligned, which is to say that they're receiving the plurality of their services or their annual wellness visit from the provider in New York, then the visit in Florida won't cause them to be lost to the practice. However, it may count, depending on the details, as leakage, which would make sense because they're receiving some of their services from another provider in another region. So just want to be very upfront about that. You know, we're trying to make sure that we're paying for 100% of primary care. And when some of that primary care goes elsewhere, we make a payment adjustment, which I think really just ensures accuracy of payment across all providers in the model. So hopefully that is helpful.
Thank you so much, Nick, Sarah, and Emily. That was really terrific. And I think you all got through many of the questions that came in. And I know we're at the top of the hour, so I will just quickly go through a few more additional resources that are at your disposal here. There are a number of CMS resources, and I really want to draw your attention to the bottom of this slide where you can go if you have more questions. The email address there is primarycareapply@telegen.com to reach out to CMS and their partners for answers about the PCF model. CMS is also hosting 2 more events in May before the application deadline to answer additional questions, and those links are in the chat. And then we've also included on the next slide resources here from the co-hosts, the American Medical Association, the American College of Physicians, and the American Academy of Family Physicians, including 2 links to the calculator that Kate walked through for both CBC Plus practices and non-CBC Plus practices. And this is the last slide, which is a thank you very much for joining all of us. As Sherry mentioned at the top, we will be putting together an FAQ document to answer any questions that we could not get to. And please continue to reach out at policy-regs@acponline.org for additional questions. Have a great evening.